Hello and welcome back for another episode of the Newbie Dentist Podcast. I'm your host, Dr. Omid Izami. In today's interview, I sat down with Dr. Ji-Hoon Kim at Disc & Queen on Instagram, based in Seattle, Washington. This interview was recorded a few months ago prior to me heading over to Seattle to attend COIS. And I had the awesome pleasure of meeting up with both Dr. Kim and Brandon Walker at Possibilities on Instagram for brunch while I was there. We got to meet in person. They were nice enough to pick me up and take me out for brunch and drop me off. And it was great to meet up with them while I was there. We ran into each other again at DIA a few days later, where Dr. Kim taught a great session on injection overmolding technique, which we talk about at length in this interview. As promised, I am trying to get back to a more regular schedule with posting up interviews, and I'm working on redesigning the website and logo to freshen things up. The podcast has been a big part of my dental career so far, and it has allowed me to form so many close friendships and find so many mentors who have helped me along the way. Dr. Kim is no exception. In this interview, we talk about several topics, including injection overmolding restorative technique, how to stay hungry and to continue to grow as you progress through your dental career, and much, much more. Dr. Kim has been up to so much since we spoke in this interview. She has launched her own podcast along with Brandon Walker called Dental Disruptors. She has also launched the Disc & Queen Academy and Institute of I.O. I will have a link for all of the above in the show notes for you guys to check out, and please do. The podcast is great. This week's interview is brought to you by my good friends at Ivoclar Vivadent. Ivoclar Vivadent is one of the world's leading and most innovative dental companies, offering a comprehensive range of products and systems that provide you with new opportunities in dentistry for even more aesthetic and efficient results and better dental care for your patients. Making people smile is what they do. To find out more about Ivoclar and their products and education courses, please head over to ivoclarvivadent.com.au. Again, that's ivoclarvivadent.com.au with a link in the show notes. As always, if you've been enjoying listening to the Newbie Dentist Podcast, please pass along the podcast to your friends, classmates, and colleagues. If you haven't already, please head over to iTunes and give the show a 5-star rating and click the subscribe button. The Newbie Dentist Podcast is now available on Spotify, YouTube, and on the website at newbiedentist.com. Without further delays, I hope you guys enjoyed this great interview with Dr. Kim.
Hello, and welcome to the Newbie Dentist Podcast, the safe place for newbie dentists to connect, collaborate, learn, and grow. The Newbie Dentist Podcast aims to provide high-quality and high-value content for all the newbie dentists out there. With your host, Dr. Omid Izami.
Okay, so I'm here with Dr. Ji-Hoon Kim, who is based out of Bellevue and Tacoma, Washington. Disc & Queen on Instagram, who's kindly given up some of her afternoon to come chat with us and share her experience in dentistry and teaching and all the great work that she does clinically. So thank you so much for coming on. How we normally start these things off is a bit of an origin story. So if you can take me back a little bit, tell me sort of why you chose to get into dentistry, where you went to dental school, and then we'll kind of take things from there.
Okay, sure. Well, first of all, thank you for inviting me. So I started my Instagram journey not too long ago, in January of this year. Yeah. And I've been really enjoying it. And actually, it's probably the first time I've actually used social media at all. And one of the things that I really love is being able to reach out and interface with, dentists, young dentists and students. Yeah. So a little bit about my background. So I graduated from dental school about 20 years ago. I went to the University of Washington School of Dentistry and really loved school. I was an older student when I started, so I didn't start right after college. I actually started about 3 years after college. Okay. So I actually was a pre-medical student when I was in college, and I was in the middle of doing my medical school applications, and I thought, I'm not sure if I'm ready to do this.
Yeah.
So, once you start down that road, you're committed.
Yeah, that's right.
Right. So I decided to take a break. And of course, coming from an Asian household, there are really only certain allowed paths. And so backpacking through Europe was not an option for me.
Yeah.
So what I did was I actually worked a couple of years doing some research in a molecular biology lab.
Okay. In the US or abroad?
In the US.
Yeah.
Abroad would have been a lot of fun, but I did it in the US.
Yeah.
And sort of long story short, after kind of searching around for a little bit, ultimately I decided that I did want to go into some sort of healthcare field. I knew a couple of things. Of course, my original fallback was going to be to apply to medical school, but then I thought, my father was actually a prosthodontist and I never understood why I never considered it before. Yeah. So I knew that I wanted to do something with my hands. So I decided to apply to dental school and start at the University of Washington and really enjoyed it. I know dental school can be hard, but I think for me, taking the break, kind of doing a roundabout journey just gave me a little bit more maturity, a little bit more perspective in life so that when things got really hard, what I reminded myself was that, this is what I want to do.
Yeah,
I got my wish. Yeah, I got my wish. And so it's all good.
Excellent. And so what was the experience like? Obviously, you've been out for a while now, about 20 years. And it's exciting for me because, normally when we talk to the guests on the podcast, most of them will be sort of in that, 1 to 5 year type frame. So they're just kind of like up and coming and progressing in their career. So looking back to sort of where you started, did you have sort of like a vision of, okay, this is the type of dentistry I want to be doing. This is the type of, practice I want to be in when you first graduated? And how did that sort of change and evolve after you kind of got your feet wet and started working after dental school?
Right. I actually kind of feel like I'm in my second career. So it's really natural for students when they first graduate. There's kind of this known thing. It's about 5 years before you feel like you've developed some proficiency.
Yeah.
So that you have some confidence when you're in clinic. So I remember early on, I always had to know the night before what my procedures were going to be the next day, just to emotionally prepare myself.
Yeah.
And it was about that 5-year point where I realized, I can pretty much just walk in and just face the day and not even think about it. And so definitely the first 5 years, it was a matter of becoming really confident as a clinician, confident not just in terms of clinical skill, but confident in terms of managing patients, talking with patients, realizing that you have the honor of treating another human being and just being able to connect with them. Really, what I wanted out of practice was I wanted clinical freedom, meaning I wanted the ability to dictate how I was going to grow.
Yeah.
And so I was fortunate enough in that I was able to join a practice where it allowed that, but I also had access and ability to use a surgical microscope from the beginning. So I've been using a global microscope for since day one, basically. Yeah. So, it's funny because when I graduated, we were still mostly taught amalgam restorations. Composite really wasn't that common. And so, as you know, with my Disc and Queen thing, so it's really all composite restorations. And, that's definitely, besides progressing as a clinician, I developed this unique skill over the last 10 years doing injection overmolded composite restorations. And so right now, kind of what I mean by entering a second career is I never really expected to launch into this new path of being an educator or a lecturer.
Yeah.
Because I'm actually really, really shy. and so it's interesting for me to find myself here. I never anticipated this.
Yeah, that's awesome. And, that self-growth and, pushing yourself outside your comfort zone is always important as well. So I think it's really awesome that you've kind of have been doing that for the past little bit and growing that, teaching side of it. Are you currently like a demonstrator in dental school, or are you actually like teaching academically as well?
So I actually don't have official ties to the University of Washington. So after I graduated, I was a associate faculty member for about 2 years, just one of the part-time clinical instructors there. I left that position, and then for about the last 8 years, I was teaching mostly outside of or within the BioClear Learning Center. So I was the co-director at the Learning Center, and I developed that curriculum.
Yeah.
I left that position this year. I should say, I really enjoyed my time there in terms of developing the curriculum and teaching, but I think that I felt like I hit a plateau in terms of being able to follow a more creative path. And I think that you reach a certain point in your career, in your life, where you really want to just continue to be inspired and continue to grow. That's so right. I would say that that's really important in anyone's career as they're launching into it, is that, if you don't continue to grow, if you don't continue to challenge yourself, then you stagnate or you become really bored.
Yeah, that's a big thing to say. If you're not growing, you're dying. So I think that's important to keep that. So you mentioned a great thing about the first 5 years of your career being sort of the major growing curve and kind of getting comfortable clinically. I remember when I was in dental school, just listening to various different dental podcasts and things as well, and everyone kept saying, the first 2 years is so important. It's like going to set the tone and trajectory of your career and stuff. So I put a lot of sort of pressure and stress on myself in the first couple of years of, okay, if it's not going well now, then my career is like going down and things aren't going to go well. So for dental students or young grads listening, what is your sort of advice in terms of how to maximize the first couple of years, be it, finding mentorship or courses or, various like CPD programs? What did you find to be the most effective way to kind of, maximize the first few years of your career to really, get off and get going?
Sure. I think that dental school, just understandably, the way that they teach, it's a disease-driven model. So students come out learning how to do single tooth dentistry.
Yeah.
And I think that what I intuitively understood, even though I didn't really identify it as such, what I intuitively understood was that I didn't understand enough about the masticatory system as a whole. And so for the first 3 to 4 years, I actually devoted a lot of my CE to occlusion studies.
Great. Yeah.
So I did Dawson Academy, I did Kois Center, and then I also did SPEAR education. Yeah. A lot of my focus and interest being occlusion driven, functional occlusion, and then from there having a better understanding about just global aesthetics or facially generated treatment planning, just depending on which center, which education you've been in. And I think that it's good to do all of those programs, but I do think you do have to have the clinical experience to tie in with it, because when you're just learning everything didactically, if you don't have the clinical experience to apply it, it takes a little bit longer for that light bulb to go off. So definitely it was a few years of investment before I started seeing enough in my patients in terms of recares and seeing how they were progressing, what some of my failures were, that all of a sudden things started to click.
Yeah.
So you do have to be patient to let the knowledge grow.
Yeah, and that's something I'm realizing now. I worked for about a year in Canada before I moved back to Australia. And one of the regrets was, you're not around to kind of see your recalls and see how your work's kind of going. So you have that, I think what they call is like geographic success, where everything that kind of worked out. Now that I've been in Australia, I've been working for, about a year and a half, 2 years, and I'm seeing some of the recalls and how things are holding up and how some things aren't. And I think that's something that only just comes with time, that, regardless of the courses you do, or you're trying to be minimally invasive and doing your onlays and things, in principle and in theory, all of these things might be good, but if you're not going to be around to actually see how things hold up, 2 years, 5 years, 10 years, I think that's when really that growth and learning comes, where you see how things are holding up. You mentioned Kois. I'm actually coming over to Seattle in December, so like in probably 3 weeks time, to do the first 2 modules.
Okay, great.
So tell me a little bit about how Kois was and sort of what your experiences were with that program.
I think that it's really kind of personality driven in terms of whether you really click with Kois or whether you click with SPEAR.
Yeah.
I know a lot of people that really enjoy Kois is the ones that really feel like they want a very specific protocol.
Yeah.
And he is very good at providing protocol and methodologies and just giving you a really good schematic that you can apply into your office right away. I think that, Spear is great because he's an amazing storyteller, and I see him as being a little bit more like providing the overall framework for me to think of all the pieces and how they fit.
Yeah.
Kois is really good for application. I think that it depends on what kind of learner you are. I think that learning all the little bits and pieces is great, but if you don't understand the overall framework, it's hard to apply it.
Yeah, I see what you mean there. Yeah, I've done some Spear online, and he's a great teacher. You can definitely see how he's just giving you the understanding of what's the actual root of the issues are, rather than just follow this and this, and just you'll get the outcome that way. So I think maybe a combination of the two might be a kind of a good way of approaching it. One thing that I've learned from different guests that I've had on the podcast is like the importance of like structure. Like once you graduate and once you start learning, if you're just doing like one-off courses here or there, it might not all tie in together necessarily too well. But if you're doing like a nice protocol or a nice curriculum-based, module-based CPD course, whatever it may be, I think that's probably the better way of learning something like comprehensively to actually be able to like apply it into your clinical practice, which is great.
Yeah, I mean, I think that you can't go wrong with either. I do know that one of the appeal of Spear Education is the fact that they have a really robust online learning module.
Huge, yeah.
Because it is really difficult. I mean, because you said you're coming here for the first two courses. I mean, you had a little bit of sort of learning fatigue. You can only take in so much information.
Yeah, it's a lot. I can barely get through a 1 hour lecture, so I need to be on an IV of a Red Bull or something.
Yeah.
Especially with the jet lag and everything. So let's, if you don't mind, let's talk a little bit clinical stuff as well. I mean, I've had Davey Allman Jr., who's the biomimetic dentistry principles and things, and I know perhaps there might be some, I don't know about clash, but just different philosophy maybe with like the injection molding techniques versus like the very incremental layering of biomimetics. So what's your thoughts? Because I mean, for most general dentists, in terms of be it in the US because of the insurance reimbursements or corporate, or even in Australia, just the amount of time and reimbursement, you don't necessarily have the time to spend like an hour and a half, 2 hours doing like one molar restoration with like pure biomimetic principles. So looking at other restorative options such as the injected molding, where it can perhaps if you're doing it properly, be a bit more efficient and get a great result at the same time. I'm just curious in terms of like, I'm sure you've had this debate with other people in terms of the two sort of philosophies of restoring teeth. What your thoughts are on that?
Okay, you're going to get me on my soapbox. I actually don't think we are that far apart. I know that they might disagree.
Yeah,
I don't think we are that far apart. So I think that in principle, I think that what we're both trying to do is provide really good patient outcomes.
Yeah,
and when you really break it down and you go through all of the protocol, the steps that we are both following, we're both advocating for basically proper isolation, urban dam isolation. We're both advocating for conservative, dentistry, direct dentistry versus, indirect. We are both advocating for, having a good perimeter seal, having, no caries at the DEJ to make sure we get a good perimeter seal.
Yeah.
We are both talking about following protocols for immediate dental sealing. We are both talking about, making sure that we are completely, cleaning the tooth really well so that we get good, bond strength in the dentin and enamel.
Yeah.
And of course, making sure that we follow really robust curing protocols. So when you really break it down, I think that there's a lot of commonality. I think that, one of the main things is really about how we're utilizing composite, how we're handling it, the number of layers. And so I still talk about layering. It's just that the way that I layer, it's not horizontal layers or oblique layers. What I'm doing is kind of more what I call concentric layering. So I'm doing internal blockout. with flowable. And then I'm making sure that the outer layer is monolithic, for a couple of reasons. One of it is to have a seamless outer crust, which provides for, I think, better monolithic strength, but also for a more resilient finish where it has better stain resistance, it has fewer defects, and it has better abrasion resistance. So all in all, I don't think that there's a whole lot of difference. In terms of the practicality, one of the reasons why I talk about injection molding or injection over molding is because I think that in terms of skill acquisition, it's easier.
Yeah.
I think if a clinician is able to come to learn it, and they can acquire their skill during a hands-on course, and then they can go to their office and Monday morning start applying it. It just means that their ability for that skill to grow into a level of proficiency or mastery, I think, is going to be better, which means that they'll actually do it.
Yeah.
I think in terms of practicality within your office, it's going to be faster because you're not doing 8 to 16 layers for a moderate size restoration.
Yeah.
I mean, we have to be practical, right? Because if it becomes so cumbersome to do, then I think that the fallback for clinicians is going to be to do an indirect restoration, which is, frankly, it's easier to do destructive dentistry. It's more profitable.
Yeah.
And I think that's the wrong goal.
That's for sure. So maybe we should have preface this a little bit. So can you just talk through injection molding technique? Sort of, I know it's hard, it made it tough over like audio, obviously, but if you can just give us like a quick overview of, like, if you're doing like a class 2 on a lower molar, sort of what the principle, like how you would do it sequence wise.
So I think that let me break it out. So injection molding, just in terms of how we're handling the composite, is, first of all, we work with warmed composite for decreasing the viscosity and having better flow. So if you think about composite not as a packing material, not as an amalgam substitute, but if you think of it more as an injectable, the reality is that composite acts more like a fluid, whether it's warmed or not. It's not going to stay contained within a box.
Yeah.
The other issue is that because of the decrease in contrast between the tooth, so white on white versus black on white, it's really hard to manage any sort of ledges or overhangs, especially in the subgingival interproximal areas. So what we're doing is, instead of fighting it, we're basically promoting it. So we're warming the composite in order to increase the flowability. Now, in order to accommodate that, we want to make sure that we clean all of the tooth, not just what's right within the cavity prep, but the outside of the tooth as well.
So is that with beveling, or are you just like micro etching it, or
both?
Yeah.
So in terms of the line angles, rather than having a sharp 90-degree line angle, we're going to create a proximal flare or a proximal bevel to allow that composite to wrap around. And so we're finishing the composite is actually almost like mid-buccal, mid-lingual area, where it's much easier to finish rather than trying to chisel away at the interproximal area.
Yeah.
And then in terms of the number of layers, so once we do the medial dentin sealing, and once we use flowable or something to do the dentin replacement to try and mitigate some of the C-factor issues, then the outer layer is monolithic. Now, in order to make it work even better, what we're doing is we're changing the tooth preparation. So instead of epoxy preparation, where we're really maximizing dentin engagement and minimizing how much enamel we're bonding to, we're doing only caries removal in the dentin, and then we're essentially wrapping the tooth as much as possible in composite on enamel. And we're trying to have it be more compression driven instead of tension driven.
Okay. Yeah.
I know it's hard without diagrams.
Yeah, visual aids. Maybe I'll if you have. I've seen some YouTube videos and stuff on obviously the technique, so I'll put it in the show notes for anyone listening if they want to go check it out later on. Just to get a better visual idea as well. To me, I was like, okay, maybe the concern with depth of cure is the main issue with bigger increments. But for the biomimetic guys, there's more like the shrinkage and the pulling on the existing bond underneath that layer of composite. So how is that sort of overcome? Is it do you allow a certain time for like bond maturity with your immediate dentin sealing before you move on to the next increments and things like the biomimetic kind of way, or
no,
you haven't found any issues there?
No, I mean, I think that really, if you think about a lot of the issues that clinicians have is there's usually three things. There's recurrent caries at the gingival margin, sensitivity, and chipping at the marginal ridge. Okay. So as far as recurrent caries at the gingival margin, and because we're allowing the composite to flow, and we're actually, instead of marginating the composite, we're allowing it to extend past the margin and creating a greater zone of a perimeter seal that's bonded to clean enamel. That's one way that issue is managed.
Yeah.
The issue of sensitivity, so the C factor issue, which is really where when you get some shrink of the composite and you start infuriating those dental tubules, that's mitigated by the fact that, we're doing immediate dentin sealing. And then, like I said, I'm going to use flowable to do internal blockout if I have a boxy preparation.
Yeah.
Otherwise, I'm changing the preparation so it's a much shallower preparation without any without parallel sided walls. So it's a much flatter. So think of it more like take a class 3 preparation on the anterior tooth and turn it on its side.
Okay.
So that's what our preparations would look like.
Yeah. So it's like a shallow pool, like a skate ramp type thing. Yeah.
Right. So it's different from a slot preparation in that it's comes up over the occlusal surface so that part's in compression. Mm-hmm. As far as marginal ridge chipping, because the outer layer is monolithic, rather than having it be layered, it's when we actually manipulate the composite a lot that we start introducing seams within the composite versus having monolithic strength. So if you think about indirect restorations, what's the trend right now in the indirect world?
Like Emax?
Yeah, I mean, well, the trend is it more towards milled? Is it milled monolithic milled restorations, or is it still layered restorations?
Well, I think most people are doing milled because they're doing it in office if they're doing a lot of it.
Mm-hmm. And I would say a lot of people, when you ask them and they say that they do milled restorations, and you ask them why, they would say, well, part of it is for strength.
Yeah. Monolithic.
So essentially, what I'm creating in the mouth is sort of monolithic hand milled restorations directly in the mouth.
Yeah. No, I think, I think the system makes a lot of sense. Like you said, once you learn it, it's less technique sensitive to like reproduce it over and over, which I think is pretty handy just for the average dentist in terms of fees and time and everything that you got to commit to it. And I like what you said in terms of the commonalities of it's still good dentistry because you're still doing your like rubber dam or your isolation and following the proper like bonding protocols and all that as well. So I think it might be a more universal approach than the like strict biomimetic kind of principle for like restoring teeth for the average dentist in their average hands.
Sure. I mean, and I know that they would probably say, well, I mean, basically the average clinician should strive, for something higher. And I guess my point on that is, just because every clinician cannot go and climb Mount Everest doesn't mean that they shouldn't go for a hike.
Yeah.
And, I really respect, all those clinicians that do, pure biomimetics, or, I mean, you see some of the masters where they do these incredible, anterior rehabilitations, with layered composites. That's great because they have the skill and because their practice model supports that. Yeah,
that's a big factor, especially for, young dentists who are just associates as well. Like you said earlier on, you don't necessarily always have that freedom to do it how you want to do it. You're kind of within the confines of how that practice operates and the type of patients and clientele and stuff that come through as well. So maybe something to, try and grow towards as you maybe get your own place and do it that way. The other interesting, I love that idea with like the Everest and hiking because I'm very fascinated by that. Just obviously in any profession like that, standard curve of there's going to be clinicians that are outstanding. There's going to be the average kind of lump of clinicians. And then obviously some, unfortunately, that are a little bit below standard. Now that you do a lot of teaching, now that you work with a lot of like dental students, like Brandon Walker, you mentioned Possibilities, who have had on the podcast as well. What do you think is some of the main either like personality traits or key factors that make people kind of throughout their career, reach that new height and become into that like 1 or 2 standard deviations above like the average dentist?
Mm-hmm. I think it has more to do with internal drive.
Yeah.
I mean, I would say that even for me at this point in my career, I'm never actually satisfied with everything that I do. I mean, I'll have some cases where I'm like, okay, that was a good case, but there's always something I can improve.
Yeah.
And so I'm, really my worst critic, as they say. And knowing that there's a human on the other side, I mean, I really try my best to do the best that I can. And I know that, sometimes it's just difficult. You can't. I think that some people, true, besides just having better manual dexterity, I think that because there is that artistic side in dentistry as well, some people lack the that visual skill, that artistic skill. It doesn't mean that you can't ever get to the point of just doing good basic dentistry. It just means that, like, I'm not going to be Newton Fall or Robert, some of the other masters out there. That's all that means. But I still like myself.
And I think, it's true. I think, obviously Instagram dentistry has a lot of pros because you get to see, all the, outstanding work that people are doing kind of around the world to motivate yourself and kind of keep raising the standard. I think getting involved in that has been really good too, because even for myself, I look back at some of the stuff I was posting like maybe 2 years ago and comparing it to what I'm doing now. I'm the work I'm doing now is still very average, but before that it was like below average. So I think just taking pictures of your work and trying to, like you said, have that internal motivation to be like, I want to get better day by day, is a pretty cool thing that we have right now that maybe dentists 20 years ago, 30 years ago didn't have, because they'll just be in their practice doing their own thing day by day and not really having that reflection to see if they're actually improving or not, which is exciting.
Right. I mean, as you just mentioned, photography, I mean, I really do, besides investing in magnification, I do really encourage people to invest in a good camera.
Yeah.
Learn how to use it, because I think it's having that immediate feedback, because I document my cases, pre-op, during the procedure, and post-op. And then there's a lot that you miss when you're just looking at it in real time versus being able to put it on the screen and, evaluating it with more objectively.
Yeah. Looking back and zooming in on the preps and, and everything. Yeah. It's pretty humbling sometimes. So tell me a little bit about, obviously, having been doing dentistry for 20 years, you've had obviously those ups and downs in your day-to-day career or procedures that don't go well. And I have a lot of classmates of mine who, we're like 3 years out now. There's a lot of burnout. There's a lot of sort of kind of stress, and some people are just kind of starting to get over it a little bit. How does that longevity come into play? Like, is there strategies of how you cope with, like a tough situation clinically or a bad outcome that's kind of helped you keep going and pushing on?
Mm-hmm. I mean, I think that you have to maintain perspective. We've all had failures. As you said, I work with students and I work with some young clinicians, and I know that feeling when you do something that's not the best outcome and you basically kick yourself about it.
Yeah.
And the only thing I can tell them is, this really literally happens to all of us. And as much as what I'm going to say right now means absolutely nothing, you're still going to kick yourself about it for, the next week, and it'll diminish over time. Just realizing that it's always going to be a work in progress, because school basically just teaches you basic competency.
Yeah.
It's not meant to make you proficient. Proficiency comes later.
Yeah.
So I think giving yourself a little bit of forgiveness. And one of the things that I always really kind of harp on is do not, unless it really is a matter of gross negligence, do not judge your fellow professionals.
Yeah.
Because unless you were there in that clinical situation, working with that patient, you don't know. I think that the more the more I practice, the more humble I become.
Yeah.
Because you're doing microsurgery on a patient that's not sedated.
In a tough environment, and
right. So it's a very difficult dance that you're doing.
Yeah.
With it's basically 3 of you at least. So
no, I think that's a great tip. And I don't know why that is. I think it's a bit of a sad part of the profession is a lot of dentists tend to bag on the other dentists to the patient. Like they'll be like, "Wow, this is terrible," or like I don't see why that's become a thing in some areas of dentistry. And it's a great point you make, because I mean, early on I learned not to do that, and luckily I had some mentors and stuff to always say, never, unless you see something like negligent, like you said, don't actively tell the patient, oh, this is bad, because you don't know necessarily if you could replicate it. And there's been restorations where I've seen, I'm like, oh, that looks terrible, and then I go to replace it and I'm struggling. I'm like, oh, I can see why, like that was the way it was. So I think if you said something to the patient, then you kind of get yourself in a bit of a tough spot that way as well. But that humility is important for sure. So any other general tips for young dentists coming through in terms of sort of what you've seen, like emerging trends, where they should focus clinically? Is it more just stick to restorative? Is there scope to, should we jump into learning like ortho or Invisalign, or should we learn implants? What's like the biggest like ROI you think you've got in the early part of your career from, obviously you mentioned occlusion being a huge part of it, but anything else outside of the restorative dentistry?
I think that I personally don't do surgery, because I know that a lot of general dentists do. They like to place implants. For me, at least with where I practice, I have some excellent surgeons. And so I feel like if I do the surgery, I'm maybe denying the patient better care. Mm-hmm. So I would say that two things. I think that having a good understanding of, and then being able to do some basic orthodontics in your practice. I think that that's a really good tie with restorative dentistry in terms of being more conservative, as long as you understand the limitations in terms of, the scope of your limitations. So, I mean, anything that's really more difficult and you're really altering someone's occlusion, I mean, I still think that would best be served by a specialist. And I think that for me, it's really working really closely with the local specialists and developing a more collaborative relationship, because at least with the specialists I work with, I refer to them, but they also refer cases to me. Because they know the particular skill that I have, and in terms of what I can do with additive dentistry. So everyone's really, the big topic now is airway dentistry. Right. And so one of the things about that is, the orthodontists, ideally, sometimes they can get a better occlusal scheme if they open up spaces. But they're kind of trained to close spaces and to sort of constrict people. And so when they know that there's a restorative option to do something additive, I think that empowers them to do something that maybe overall health is better for the patient. And so, I really enjoy those kinds of collaborations with my specialists.
That's really cool. And I think that having that relationship is really important, like you mentioned, and a great tip for new guys, because I think a lot of times we'll just refer out. We're not really sure who the person is. We haven't actually met them face to face or gone to see their practice and see what they're doing. And one good tip I actually recently received from one of my mentors was, if whatever it is, if it's endo that you want to get better at, or if it's implants or wisdom teeth, whatever it may be, like make a policy with your referring specialist that if you refer a case, that you actually go and watch them do that treatment on your patient as a good learning tool, because you've diagnosed it, you've kind of treatment planned it, you've referred it off, and then just try and make the time to go over and see them do the actual procedure on that patient.
And that's absolutely true. I mean, I would say I had a couple of early on bad clinical situations, and part of it was just being young and being naive, and so I came out and decided just to do a general restorative practice. And so I kind of held the specialist to a little bit of a higher ground. And I think that one of the things that, Frank Spear talks about is it really shouldn't be a tiered relationship. It should be more like you're the generalist and then they're the specialist. I mean, you have your own specialty in restorative dentistry. Because I can tell you most of your endodontists do not want to have to do any restorative dentistry, even though I encourage that. And so what I did was I had referred a couple of patients and had deferred to the specialists. And you have to remember, as a general dentist, you have to be the quarterback. And so the cases did not go well because I gave the specialist a little bit too much freedom, a little bit too much what should I say,
leeway,
professional discretion, and realize that no, actually the specialists don't always know everything in terms of how to achieve the best outcome for the patient.
Yeah.
So, for me, that just taught me that even if I'm disagreeing with who I thought was kind of like my mentor, my higher up, that basically I'm doing it for the patient's best interest.
That's a great point. I haven't had anyone say that before. I think that makes a lot of sense because you're, as a quarterback, you're the one that's seen the overview of the whole case, especially if you've, put in the time that you did to learn full mouth occlusion and restorative. So the specialist, whatever, if it's the endodontist or periodontist doing an implant, whatever it may be, they're really focused on that one thing. So they might not necessarily have that same knowledge of the overview of everything going on that you would do. So I think that's a great point. I think
I think that, I think that initially when we come out, we're a little bit intimidated, right?
For sure.
But the thing is that at least, I think that most of the specialists that if you ask them, if you work with them, they're really happy to discuss cases with you and to actually teach you. And then it becomes more of a collaborative back and forth learning effort.
Yeah, that's awesome. No, that's a great tip. What about study clubs and things? Is that something that you've utilized a lot in your career? Or?
So I always was always part of a study club. So in the first half of my career, I did a couple of study clubs, one of which was a Seattle study club.
Oh, yeah.
And then after that, right now, currently, I'm part of a Spear study club and a study club with my periodontist. So he has a study club. So a lot of your specialists will have certain study clubs that they run. Yeah.
That's awesome. No, I think that's super cool. And like you said, that second career that you're having, like 20 years in, a lot of people are just kind of plateaued and just set in their ways and kind of just winding things down a little bit. For you to have kind of had this like resurgence and motivation to get on social media, get on Instagram, start posting your cases and growing. And I see you've what is it that you've started here? The template, the Smile Design Gauge. Tell me a little bit about that project.
So actually that came about because I told you that early on in my career, I went and did Dawson. I did Dawson courses. And one of the things that I learned there was about sort of building occlusal schemes, building anterior aesthetics. And so I took all the hands-on courses, and I still do all of my diagnostic wax ups as kind of like what I do when I'm watching TV. And so one of the things that I came away with when we did that was we learned how to do, as a starting point for building the anterior aesthetics, using a golden proportion rule. And that's always my starting point, but it's not necessarily my final end point because there's a lot of different proportionalities that exist, in the population.
Yeah.
But when I started doing a lot more injection overmolded restoration, so what happens is because you're using these matrices are creating the form, you need to be able to make decisions about the width of the teeth, the proportionality of the teeth. Yeah. And what I wanted was the ability to skip the sort of the lab smile design phase.
Yeah.
And just to go straight to a chairside smile design phase. And so what I needed was something that I could use intraorally. Yeah. So the Smile Design Gauge, it basically has 6 sides, 1 blank side for using just doing contrast photography. The other 5 sides are based off 5 different central incisor widths. Okay. And it's really just to help you to see the mesial to distal spread of the smile. And I can do my diagnostic workup with photography. Yeah. It becomes a really good communication tool. So I use it to communicate and make proposals to my patients. I also use it to communicate with my orthodontist.
Yeah.
So all the orthodontists, they'll say, okay, so if you've got underside lateral incisors, where do you want me to put it? Well, you can take a photo, or he can take a photo. You can communicate with that.
Yeah.
And then when you're executing your case, it's a ruler. You're using it as a ruler, actually chairside. That's
a nice tool, because I think a lot of times now we take pictures and we have like those templates on like a PowerPoint or a Keynote or something that we can just kind of drag. But I think the value of it, one is like intraoperatively, you can like use it as well and just to check and see how you're going with your buildups and
right.
Yeah, super cool. So is this you can buy this online, just on the website, or?
Yeah. So you can right now. The only place that it's available is with BioClear.
Okay.
Yeah. And then I'm kind of working on another project sort of related to that.
Yeah. Okay, cool. So I'll put a link on that as well if anyone listening wants to have a look at those and check them out. Definitely a great tool. Okay, so thanks a lot. I mean, we covered a lot there, which covered sort of some early career tips and tricks to kind of get going, including like, full mouth occlusion courses. I think occlusion is huge. You keep hearing about occlusion and stuff in dental school. And yeah, you get your like, MIP and CR and guidances, but that stuff doesn't really mean much until you kind of get the bigger overview of how things are kind of fitting together and forming and functioning all in unison. And when you trying to expand your clinical skill set beyond like that single tooth dentistry to full mouth, I think it's really important kind of knowledge base to have. And I think it comes across when you learn the stuff and you start talking to the patient, everything clicks and you can show them like the wear facets and how things are actually fitting together like a jigsaw, which is pretty cool as well. It's like a bit of a detective journey, which is always fun. So
yeah, well, the thing about the mouth is that it ultimately has to be functional, right?
Yeah,
it doesn't matter how pretty the car is if it doesn't run.
Yeah. That's right. So before we jump into the just quick rapid fire to end things off, anything else you want to mention or anything else you want to put out for the listeners?
I think really just, just philosophically, just, really stay curious and stay active. And, in dentistry, you have a lot of different avenues, a lot of different avenues that you can pursue. And so instead of just getting stuck in a rut and thinking, losing interest, find a different path.
Yeah. And I think that search is important. Really see, because you might, even I've been working such a brief time, but 1 month I'm like, oh, I really like surgery. 1 month it's like, oh, I like endo. So I think it might just take time to really get enough reps in each thing to be like, okay, I really actually do like this. And I want to really try and, improve on this kind of 1 or 2 procedures.
Right. And 1,000 hours and whatever.
Yeah. The Malcolm Gladwell.
Yeah. Yeah.
Awesome. So how I end these off is just a quick, fun rapid fire just to wrap up. So what's your favorite pizza topping?
My favorite pizza topping?
Yeah.
Oh, I would say I'm kind of more of a carnivore, so meat.
Meat. Yeah. What's your favorite like band, artist, or musician?
Oh, that's a tough one. I have a really eclectic, strange taste in music, so I really don't have a favorite one. So it's pretty much if someone sends me a song, that may be my favorite one for about a week.
Yeah. What do you listen to at work? Is it just radio, or you have like certain
at work it's just radio, so I get to suffer whatever the front office person chooses.
Yeah. What's your favorite Instagram account to follow? Like dental or non-dental?
Oh, well, some of my favorite ones. Oh, I love Dental Tube. I love Ryan Noland. I love Possibilities. I love Rafael Sampaico. He's amazing. Some of his, I always like to follow him and just the anterior reconstructions that he does. Let's see, trying to think here. So in terms of all the ones that I check all the time, let's see, I'm spacing out on her name. So I like Ashley Izzati. I like who else here? Amanda C is always amazing.
Yeah.
I love. I don't check it all the time, but of course Miguel Ortiz. I love his Pros Lit. I just go back and check that every once in a while.
Mm-hmm. Photography.
Yeah. Yeah, just anything. I love anything that gives me like all the sort of nerdy dental material stuff.
Yeah, not just before and afters, but more kind of process driven.
Right, and then the other ones are people that basically give you some aesthetic, something that's beautiful, just that's aspirational.
Yeah, for sure. What's your favorite tooth to work on?
My favorite tooth to work on. Actually, I would say anterior teeth and bicuspids.
Yeah. What's one procedure that kind of makes you question your career choice in dentistry when you have to do it?
Oh, gosh, I would say surgery. I really don't like doing extractions at all. I will run away from extractions if at all possible.
And if you weren't doing dentistry, what career would you be in?
If I wasn't doing dentistry, actually, I probably would have been in medicine doing surgery.
Surgery.
So yeah, still.
It's funny how in dentistry you don't want to do surgery, but otherwise.
I know, right? I mean, I think if it was like isolated to like an eyeball or something like that, I think it'd be okay. Not something really big and gross like the joints. I don't want to do that.
Yeah, and luckily they'd be asleep probably, so you don't have to deal with it.
Right, exactly.
Awesome. Thank you so much for coming on. It was a lot of fun chatting with you and picking your brain on various topics and things. It's always fun to get a little bit clinical as well and talk about like we did with the injection molding technique and things. So I'll definitely put some resources for people to check those out listening. And so definitely check out Dr. Kim's work at Disking Queen on Instagram. Actually, we didn't talk about any disking. So what made you come up with that Instagram handle?
Oh, that moniker, actually, it was sort of a term of affection that was given to me by Mark Konings, who's a friend of mine.
Yeah.
And so he was spent a lot of time at the Learning Center teaching. And what I did was, when I was teaching at the Learning Center, I kind of developed this disking protocol.
Okay.
So I actually have a webinar. It's that I did with 3M, and it's like creating microaesthetics and anterior restorations, and it's all sort of based around using the SofFlex disc. And because I use that as like a multifunctional tool, so it's kind of like a milling tool, and then it's a shaping tool, and then it's a refining tool, and and so like every time people want to take a burr to the anterior, I slap their hands because I'm like, no, don't do that. Use the disc. And so that was kind of how it came about, because I was wielding the disc and using it for a lot of different things.
Yeah.
So I had a dental student, Esther Dental. So she's one of the students that is at the school as well. So she was really funny. She was quizzing me about what I use for heme control.
Yeah.
And I would say, well, use some ferric sulfate or use some, aluminum, whatever, right? And she goes, oh, I just assumed that you would have used a disc to cauterize the tissue. So anyway.
I think disking, it has for the front teeth, it's not so bad, but for posteriors, if you're using it for like removing your flash and things, it has a certain dexterity that takes a little bit of time to kind of get down, because it is pretty bulky with the mandrel and everything to kind of get the various angles and things. But once you get it out, it's hard to replicate that result with like any burr for sure.
Mm-hmm. Yeah.
Excellent. Thank you so much for coming.